Thank you all for joining us for today's HTRC education series. My name is Haley Bell. I'm the program manager for the Heartline Telehealth Resource Center, and I have the pleasure of hosting our session today. I do have just a few quick logistical notes for you before we get started. The session is being recorded and we'll share it with you afterwards along with the slides. Please use the chat for any questions you have throughout the session. If we have time at the end, we will get to them. If not, we will include the questions and answers in that follow-up email. And if you would like a completion certificate, please contact us at htrc@kumc.edu. We will get that email put in the chat, and just please be sure to include your full name as you would like it to appear on the certificate. So yeah, let's go ahead and get started. I would like to introduce our speakers, Dr. Bradley Anderson and Jared Droz. Dr. Anderson is a board-certified internal medicine physician with a background deeply rooted in rural Missouri. He earned a bachelor's degree in health science, specializing in radiology from Missouri Southern State University. Following that, he pursued a doctorate in osteopathic medicine at Campbell University School of Osteopathic Medicine in North Carolina, followed by a residency in internal medicine at Oklahoma State University. He also holds a Master of Healthcare Administration from Oklahoma State University and a Certificate of Artificial Intelligence in Healthcare from Stanford University. His career journey led him to join the faculty at Oklahoma State University, where he now serves as a clinical assistant professor of internal medicine and holds multiple administrative roles, including vice chair of OSU MC Internal Medicine Department, medical director of virtual care, and medical director of the hospitalist at Cleveland Area Hospital. His commitment lies in bridging the healthcare gap of medically underserved communities, schools, and hospitals, particularly through the innovative avenue of virtual care, ensuring that specialized medical expertise reaches those who need it most. And Jared Droz, our other presenter. Jared has over 15 years of progressive leadership experience in healthcare operations and has successfully driven innovation and growth across hospitals, outpatient, academic, and virtual care settings. Skilled in strategic operations, physician alignment, and performance management, Jared has consistently improved financial performance, patient outcomes, and team cohesion in both nonprofit and for-profit environments. Currently serving as the director of virtual care at OSU Medicine, Jared is passionate about leveraging technology and collaborative strategies to enhance healthcare accessibility and delivery. Jared also holds a master's in healthcare administration from Oklahoma State University Center for Health Sciences and is a member of the American College of Healthcare Executives. So thank you so much both to Dr. Anderson and Jared for being here with us today. I will go ahead and pass it over to you all.
Perfect. Yeah, thank you so much for having us today. We're very excited to be able to talk to you guys about kind of everything we've been doing here at Oklahoma State and appreciate those introductions there. So I'm Brad Anderson. I'm the medical director of virtual care, and Jared and I are going to kind of bounce off each other here and talk about the different technology and navigators that we have used here at Oklahoma State to build our virtual care practice really over the past 2 years. Oklahoma State has done virtual care for quite some time. We actually started virtual care back in the early 2000s with our HIV clinic, but then obviously when COVID happened, we quickly expanded our virtual care lines, and since that time, we've rapidly expanded our services across the virtual care network to include many hospitals and what we're doing in Oklahoma. So kind of just to set the stage about Oklahoma and the healthcare that's happening in Oklahoma, you can see this map here. This is from the Rural Health Information Hub, which is a fantastic location for some great information about rural healthcare and just the current climate of healthcare across the United States. But you can see this map showing really the healthcare professional shortage areas in Oklahoma, particularly when it comes to primary care. In Oklahoma, there's really two large metropolitan areas, and that's Tulsa, Oklahoma, and Oklahoma City. You could see from this map kind of those areas actually where Tulsa and Oklahoma City sit within the geography of Oklahoma. Really everywhere outside of those two large metropolitan areas are really considered healthcare shortage areas. And so here at Oklahoma State, we have made it our mission to really target the rural, underserved, critical access hospitals and communities that really need increased access to healthcare. And so we say there's a lot of people at Oklahoma State who are concentrating on healthcare here in Tulsa. We're looking at the areas outside of Tulsa, and that includes about a third of the population. So there's about 4 million people in Oklahoma, and about 1.5 million of those people live in a rural professional healthcare shortage area. We really believe the tool to being able to increase that healthcare access is using virtual care and technology. And so that's kind of where the lines cross when you come to rural counties that have low access to healthcare. Really, it's that line that crosses that virtual care technology that allows us to bring our high quality physicians to the rural counties to increase that access of care. One thing that we have here at Oklahoma State is we have, board certified physicians who are often teaching in our residencies. So they're highly qualified physicians who, are up to date on a lot of the healthcare information and a lot of new healthcare initiatives. So we really believe that we could take these high quality physicians and be able to spread them across Oklahoma to allow an increased access of care. And we've done that through a variety of ways. We'll talk about our service lines here in a little bit. Jared, did you have anything else to add to that kind of thought there?
No, I mean, really, I guess yes, in a way, I would say, obviously, we call, like you mentioned, when we talk about virtual care, healthcare, obviously, for us, it's just care, right? So anytime we get an opportunity to talk about that, obviously, we know that virtual care is just healthcare. And so when we can partner that and package it with what we do in our residency programs, extension to obviously rural Oklahoma, and how we can, infuse that with obviously high quality healthcare. That is really impactful. So yeah.
Yeah, so let's talk about some of those service lines. But first, you may hear me call it virtual care a lot, and you may ask the question, why do you call it virtual care and not telehealth or telemedicine? We believe here at Oklahoma State that a lot of these terms kind of fall under this big umbrella of virtual care, and we really provide more than just telehealth. We provide teleconsults through our different service lines and consultants. We provide some population health, which I'll speak about here in a little bit, as well as digital health and some therapy. So really, it all falls under what we call virtual care. So we like to use the term virtual care to umbrella term that we do more than just telemedicine. We're situated in multiple different hospitals, multiple different schools, and we'll talk about that. And each of these are a different entity that falls under virtual care. So that's why we call it OSU Virtual Care. I've talked a little bit about this, but really from the top down at Oklahoma State, we've really made it a mission and an initiative to use this technology to really reach these states, reach these critical access underserved communities to provide not only primary and different types of healthcare, but also specialty care. And so this is a quote here from our president here at Oklahoma State Center of Health Science, talking about the way that we're going to use technology to really provide specialty and increase specialty care and increase access to care, hopefully help with some of the healthcare work shortage that we continue to see based on the maps that I showed you earlier. Here's kind of a list of some of the service lines that we provide. A little bit about each of these service lines, just to kind of give you a broad overview of what we do and why we have chose these specific service lines. But one of the things that we like to do at OSU when we go and talk to a rural community or a rural hospital is we really like to sit down with them and have a conversation just about what that system, what that hospital, what that community needs. And a lot of times, it's specialty care, it's behavioral health, it's things, and so we really try to bring that to that community. So we kind of flip the script, go to those communities and say, hey, we have a lot of different service lines, but what can we do to help you? So these are some of the service lines that they have come up with and asked for. So I'm an internal medicine physician, we talked about earlier. Uh, I'm a hospitalist by trade, so lead our hospitalist programs, virtual care perspective here, see virtual care. We do two different models with our hospitalist care. We do a direct model where we're able to actually directly see the patient on make orders, do admission, whatever may come out. But we also do a hospitalist consult model. The reason that came about was several different community hospitals affiliated. I think that's an important topic to say is that we have no affiliated hospital. So many of the hospitals that were unaffiliated actually hospital were unaffiliated with virtual care. And so we go to these hospitals and they already have kind of a preset hospitalist program that's often driven by local family medicine providers or APPs that are in the area, but they just have the need to ask some more complex questions about those patients. So anyways, the hospital service line, we were able to keep that patient in the hospital and provide them with the care they needed, but keep them in the rural community, keep them in that status of the swing bed status. There was actually a swing bed patient, and we were able to provide them with the care they needed. They didn't have to be transferred to a higher level of care, and it was a win-win for everybody. Yeah, so some of the other service lines here I'll talk through just real quickly. We do a cardiology consult, both outpatient and inpatient, to provide cardiology access to these rural underserved communities. About 53% of the counties in Oklahoma, recent study done, did not have access to a cardiologist. And so that specialty line is definitely needed throughout Oklahoma. We do a behavioral health, both in the emergency room and actually inpatient as well now. These are board certified psychiatrists who can help provide support to those ER physicians for medication adjustments if needed, or inpatient psych placement if that's needed as well.
So our psychiatric addiction medicine line obviously supports ER, either APPs or ER physicians in terms of looking at, either medication at the time of visit. Also, how can we either keep a patient from, being, unnecessary transfer to an inpatient unit, all of those things. So it's a great level of support. A lot of the visits that we've seen here recently, probably over 50% at least have been or had some component of a substance use disorder, right, that's attached with it. And so when you have both of those kind of as a dual diagnosis, if you will, it's great that our OSU physicians and psychiatry team and residents are trained in both of those. So provides that. Obviously, we kind of continue on this kind of timeline. We've got school-based virtual care that we offer that we're going to talk a little bit about. It's great that we can provide kind of medical visits and behavioral health therapy to our rural public schools here in Oklahoma. We have around 14 sites, and within those sites, obviously, they could have either from one location all the way up to 7 or 8. And so kind of varies in different level of kind of attendance or total students. And so that program really, when you look at kind of that, back to kind of Dr. Anderson's slide earlier, this is a demographic that, again, access to care is really impacted. We've got a school that's, 20, 30 minutes away from the closest kind of clinician. And so for a lot of those families and students, it's great to have that. Next, obviously, we do a virtual mobile clinic, which we'll get into here, talk about how we partnered with our OSU Extension Office. In the state of Oklahoma, the Extension Office looks a lot at agricultural resource, and they do some water testing, they do nutrition out of that. So we thought, hey, how could we help and provide kind of healthcare, infuse that with what we do in our rural communities with a trusted brand like OSU Extension. So great collaboration with us. And then obviously we support some primary care virtual efforts. And then one being obviously our Choctaw Nation Urgent Care. That's a collaboration between one of our tribal partners here in the state of Oklahoma, a smaller footprint model that is for us, at least in the state, kind of a new and innovative way to approach how we can create access. And the last thing we're working on is a ER telemedicine training program. This is something that looks at kind of a two-phase approach. Phase one being we get education, looking at gearing this toward APPs in rural Oklahoma that are tasked with running and staffing an ER by themselves. And so how can we educate, provide them some additional emergency medicine training with our OSU board certified emergency medicine physicians? And a lot of these courses obviously are ones that even our residents go through. And so there's a 3-month course for that provides, in-person learning, online, but really the neat component to that is kind of a 2-day sim center at our OSU Center for Health Sciences campus. And so they're able to come and get hands-on experience from different array and different sorts of different emergency medicine techniques. The last part of that, the phase 2 approach, gets that hospital a 24/7 ER, clinician to clinician consult. If there's anything that comes through that they need support on. Also, with that, they can also see patients as well, but mainly this is kind of geared and looking at supporting our rural APP providers across the state. So this kind of gives us, just to give you an overview of kind of where we're at. Obviously, in the state of Oklahoma, southeastern Oklahoma, when you look at all of the healthcare markers and benchmarks, obviously really, really struggling in that southeastern Oklahoma corridor. And so for us, that was a challenge that we wanted to answer. And so as you can see, we've got a lot of our schools, we've got extension offices, different hospitals that we've connected there, starting to make our way out into the Western Panhandle. As you can imagine, there's geography is definitely different out west for us in Oklahoma. And so when we are looking at all of those sites out there, I think one county actually, I'm trying to remember which one, but one of those out west does not have a physician in the county. And so one physician has to come from, a couple counties over to help support them. And so just, gives you an idea of some of the landscape there. Obviously, our goal with virtual care services, like we said from the top, how do we increase access? How do we get this to underserved communities, critical access hospitals? How do we look at those patients staying at home, staying close to home, staying where they've got friends, families, relatives to help support them? Also, how do we keep revenue in those critical access hospitals? So as we're looking at that, that is kind of the first thing, that we look at when we speak with a hospital or we get into a conversation. How do we use, obviously, technology? How do we use virtual care as a means and a way, just another tool in the tool belt for us to keep patients local, keep revenue local, and keep those rural hospitals thriving. So again, this is obviously just a call out. Another one of our team members here, Robin Dotson, you'll see on the left. She's our virtual care coordinator. We don't run without Robin. She does a lot of our operations in terms of day-to-day communication. But as you can see, this is us with in one of our hospital sites using our TytoCare device, which we'll talk about here. And so for us, as we look into this, it's a small footprint. It's easy to connect for hospitals. It's easy to connect for nursing staff. It's something that we don't want to create a burden for when we look at telehealth adoption. That's really key and critical that it just works. And we're fortunate enough to have that there. So speaking about TytoCare, here we go. And obviously, this is what we use not only from school-based sites, hospital sites, all the way to school-based sites. Everything that we do and everything that comes out of OSU Virtual Care comes with, the iPad and our TytoCare device. Again, it connects small handheld otoscope, stethoscope, act as obviously a thermometer as well. So that's great. A high def camera.
So, yeah, like Jared said, one of the best things about this is the ease of use, right? So, it's just easy for the nurse to be able to pop those different instruments on. I could direct the nurse how to do the exam directly on that little device there, held within the palm. So it's very small footprint. And so we're able to do basically a full exam with this little device. And it has that high definition camera on the back, so I could see wounds, rashes, whatever may need to be done. We could see in the ears, we could see in the mouth. So it really provides just a simplified way to get a quick, easy exam done with the assistant of a medical assistant or a nurse on the other side. Andor is our other platform that we use. Andor is our web-based EHR system. The reason why we went with Andor is because it is agnostic to the other type of EHR system that we're implementing with. So we're in many rural, underserved hospitals that are using all sorts of different EHR systems. We don't want to have to log into each of those EHR systems to ease the time that our physicians are trying to remember logins and trying to log into devices. So we get to stay in Andor and integrate with these other hospitals so that they could stay in their EHR system and we could use Andor. And we can wrap TitleCare into Andor, and that allows for easy connection, easy integration, and just continued growth across, unaffiliated places. And so Andor has allowed us to do that. It also allows us to bring in really anyone who has a cell phone in the United States, honestly. So maybe a son or a daughter who are in California who want to be a part of the visit. I could send them a HIPAA compliant link and they could actually join the visit when I'm seeing that patient. And so it really allows for, continued communication across all of the healthcare system and collaboration with not only, other providers, but also other family members. This is a recent initiative that we started, which was a hybrid clinic in Antlers, Oklahoma, which is definitely in a rural, underserved part of the community. And it is a virtual kind of walk-in urgent care style clinic, and it is connected with the Choctaw Nation, so a tribal clinic that also sees non-tribal patients. And it is probably about a little over 1 month old that we started this, and we've already seen almost 100 patients in this clinic. Our provider is virtual. You could see Jen Vandergriff, our provider, there on our device. And then they have a nurse, an RN, who actually is there on site and helps with the visits, helps room patients, and does labs. And then they have somebody in the front office who is checking in patients. But really, it's a small footprint. Don't need as many people there employees there trying to help check people in. So it provides a small footprint, but also allows for patients in a healthcare shortage area to have a healthcare clinic that they could go to. And it's been fantastic so far. Jared, do you have any other thoughts on that?
Yeah, just to call out. So 2 exam rooms, right? So a really small footprint. They do have a small lab. They'll do some very basic point of care testing, and really, looks at, fever, earaches, cough, cold, some of those more walk-in style symptoms. And connected to this, obviously, we loop them back to kind of their primary, if there's anything more chronic care related, bridge them, if you will, right? Is kind of the term that we use. And so, again, I think it's something that's a great pilot for us to see how we can take this model here. I know others have done it successfully in the past, but within the state of Oklahoma, how do we make this partnership with the small footprint work for others that are, again, really far and away from any close, reliable kind of care that they can depend on. So great model. Interested to see how this kind of continues to turn out for us. So.
Yeah, and this picture here is the chief of the Choctaw Nation, Chief Patton, there with Johnny Stevens, our president, and Dr. Hill, their chief medical officer for the Choctaw Nation. So great collaboration between all of us, along with Mike, Jared, and I, who are representing, OSU Virtual Care. So great photo of what we could do in rural communities. I'll let Jared kind of take over a little bit more here and talk a little bit about our business ventures here with virtual care
Yeah.
and how we've kind of set that up, and we'll go from there.
Again, telehealth adoption. We looked at this. Actually, this is an article from the American College of Healthcare Executives. I think this is kind of the first article that I've seen really look at and pinpoint connecting financial indicators to who have adopted telehealth, at least that I've been able to find. Open to hearing and seeing other articles, but would direct you there for more lengthier, in-depth analysis. But when you look at those who were obviously persistent telehealth use adopters and their operating margins, how that's connected, you can see, 0.9 to 3.8 in terms of a margin, where those who obviously had a great opportunity to implement telehealth within their system. And then obviously, as you can see, we're telehealth adopters where they were either didn't adopt telehealth, don't have that currently, or maybe they're going through some type of strategic planning or working exercise to eventually adopt that, but looks at lower operating margins that you can see. So again, the use for telehealth is there. Obviously, some of that ROI that we're always kind of looking for and needing in some certain conversations is kind of in there. And again, there's, I think, I saw somebody in the chat. I think there's the link at the end of this. We'll definitely be able to link that to you. So So when we talk about school sites, obviously, this is some of our team and group here. Again, we support 14 rural schools within the state of Oklahoma, anywhere from 200 students all the way up to 3,000. And for us, when we're looking at, again, our main focus this last year was Southeastern Oklahoma schools, how we can close that gap in access to them. We first started this, obviously, we did not have any testing. So we were not performing any kind of strep or flu testing. It really was a lot of ear infections, a lot of sick care in that way. But, as we look at how do we assess year 1 to year 2, this coming school year, we're actually going to start including flu and strep testing. So I think that's going to be a great addition to what we offer. And I believe obviously visits for that will rise. I think overall last year we had around, I think 60 to 70 visits from all of our school sites. And so we're working through how do we get kind of our rural families and schools better adoption rates in that. We try to go, as you can see, we go to a lot of open houses, especially beginning of the school year. We have our community health worker that actually will attend. She's local in Southeastern Oklahoma, so she'll attend school functions, school events, at least to promote the service and show that we're there. We're actually working on, Dr. Anderson and I are working on what would a virtual visit look like? It's a short 30, 45-second clip that we're going to be sharing kind of site-wide. So at least if you're a parent or a guardian, hey, here's what a virtual visit would look like, right? When we say virtual visit, sometimes folks equate that to, oh, you can see me in my house. Well, yes, we can do that, but also we can use virtual visits right there with a nurse so we can address what your need and concern is. So that's a great thing that we've got coming up. And then for us, it's a lot of times we've even thought about connecting, opening up kind of Zoom meetings for parents who have questions. With any of this, the foundation of what we're doing is not trying to be someone's primary care and take that from our local physicians or local clinicians in those area, but how do we bridge that back to them? So within or we can send obviously a secure link to whoever their primary care physician is. That's in our intake packet that we ask parents and guardians to fill out. So we can take that visit, obviously share that information with them so they know kind of what either, if we prescribe an antibiotic, right? They can keep that continuum there and be aware of what's going on. Hospital site visits, like you heard Dr. Anderson mention, all of these sites that we have, small footprint, small critical access hospitals, very rural. For us, when we go into a hospital site, our main focus is how do we help keep your patients there? How do we keep, again, revenue there in your hospital? The other thing that we look at doing is what's the level of expertise of your nursing staff? What facilities do you have or what equipment do you have available? What is it that we can do to try to find ways to keep additional patients there clinically safe and appropriate? But also know that at the end of the day, if somebody needs that higher level of care, it's not safe for them to stay there anymore. We're a great opportunity, a great partner for that critical access hospital or rural hospital. We could take them, keep them for a few days, and obviously give them back in a swing bed scenario to that hospital, again, keeping revenue, keeping patients there locally. One of the things that I know, one of our hospitals, Dr. Anderson, go back one more slide, sorry. Dr. Anderson in one of our hospitals is a medical director there. Some of the work that he's been able to do when we talk about expanding care, we talk about expanding the ability to keep patients there. I know he's driven a lot of different policies and protocols in education training for that hospital to help expand that and help, again, to keep more patients that need to be kept there locally. Again, the great thing about our technology that we use, we can loop in family members, we can loop in other folks that want to be part of that care journey. They could be different states away. And so it's really exciting to see that. All right, this is our extension office clinic. We talked a little bit earlier about this. The state of Oklahoma, each county has their set extension office. And so for us, it's a great pilot and opportunity to work closely with our OSU extension office, who again, mainly focus agricultural related, water testing, even different, ag-related items. They'll do nutrition, they'll do anything in terms of livestock training as well and education. A lot of activity within our OSU extension offices. They have a really, really wide reach. And so for us, connecting with them, seeing the brand of OSU coming together with OSU Extension, OSU Medicine, and kind of merging those two, you get the trusted brand in kind of that rural community. And so this is our kind of orange vans. We have two. One is primary care focus. The second is more cardiology related focus. And so we're actually getting ready to kind of start our cardiology van probably here in the next 3 to 4 months. I would hope we're kind of gearing up with some mobile echo devices, different things that we can do. But in each one of these, it's free to the community. We, again, are, like the title says, bridging that gap and kind of bridging them to a primary care office that's local in the community. Like we've said before, that's our focus. We don't want to come in and take any patients away from our local clinicians. But how can we find somebody that maybe hasn't seen a physician in 2 or 3 years, maybe doesn't have the means or the resources? So how do we can help them get a good baseline? And then also our community health worker, Vanessa, is at each one of our extension office clinics. How can she help with insurance? How can she help with all of those SDOH items and all of those kind of things that impact our care outside of the 4 walls? So whether that's electricity, food, water support, whatever they need in terms of those resources. We like to call Vanessa she's kind of our Swiss Army knife. She rolls around in her car and she pulls out anything from, forms to can openers, you name it, anything that toothbrush, toothpaste, hygiene items, anything that our patients would need. In one of our extension offices, some of the things that we've been able to do and what kind of birthed from this is we had a patient that came up that had obviously when they do can drives, a lot of them aren't pop tops. She didn't have access to a can opener, so she's with a rock trying to get this canned food open. And so it's a great opportunity. Obviously we were able to help her open that, but that gave us the idea, hey, we need to get some can openers. We see a lot of that in our community. We did that. That also kind of spurred on a hygiene drive that we did through the community as well. So got everybody in kind of the small community involved in that. So some really good work coming out of that in terms of patient volume and what we're seeing. Typically on average for our extension office clinics, we kind of go from 3 to 4 a day on average to sometimes, there's been an occasion where we haven't seen anybody. A lot of things that impact that could be weather or holidays or things going on that way. But for us, the main goal is to, again, connect folks with primary care. How can we get them back on that kind of healthcare journey? So next slide, please. Oh, do you want to add something there? Go ahead.
Oh, just really quickly, I think that's the important part of this clinic, and what we could do is that we could really bridge those, mild to moderate risk patients who aren't being seen, who may have, undiagnosed diabetes, hypertension. We could really bridge them back into the community and get them back to primary care. And it's just that connection, that trusted name in the community to help those patients. So fantastic thing that we have kind of started. We're really excited about this clinics.
Yeah, there we go. And here's a little look at the inside of one of our vans. Again, it's really a full functioning clinic, right? On where you can see kind of that monitor there. Obviously, we're able to have our physicians or clinicians that sit in Tulsa can see patients. We've got a nurse on the bus, which is helpful to draw labs that we need. Again, baseline lab work gives us a great idea of kind of what's clinically going on. For us, we'll obviously some scripts for antibiotics. Again, we'll bridge some of those maybe more chronic care medications if they need. But again, mainly just looking to get them connected back to healthcare and a healthcare provider in general. So yeah, next slide, please. Yeah. Our community health worker, I say this every time I get an opportunity to, I would hire 10 more if I could. The impact that obviously a community health worker has or even social workers in general or case management, the impact they have outside of, again, the 4 walls of the care setting play a huge role in how people get continued access and how they kind of can continue that healthcare journey. So for our community health worker, Vanessa, she's able to sign folks up for insurance, whether that's Medicaid. She's able to help with, again, bills, transportation, you name it. There are tons of stories that we could probably sit here and talk about that she's had an impact in sharing. And so we're working on organizing a lot of that data to come up with some, impact report, if you will. But again, the comment I mentioned earlier, or the experience we mentioned earlier about, can openers being one, is just a, testament to what she does kind of day in and day out. Obviously, the other side of what we do with Oklahoma State and in our role, this is Congressman Kevin Hern. And so, came to take a tour, him and his staff, of everything that we do virtually. And so he got an opportunity to come tour the van, how we support rural from everything that we listed, before, from hospitalists, cardiology, behavioral health, primary care, all of that. So obviously having our, congressional support is huge when we look at policy and, adjustments that are needed at the state level to help us continue to provide that care to patients. So kind of wrapping up here, obviously we've got, we're on social, Facebook. Please follow us there. Emails here. This is obviously myself, Dr. Anderson, Jen Vanderwerf, who is our PA, always willing to kind of help support and ask questions. And obviously our website, stay connected with us that way. But yeah, it's been a pleasure speaking with you all, excited. And again, what we do is our main focus is just rule. That's what we do day in and day out, creating access, bridging those gaps, creating and thinking of different ways and models that we can help support, again, keep our rural hospitals alive, keep revenue in those hospitals, keep patients there, and keep care local. So again, thank you guys. Dr. Anderson, any final comments from you?
Yeah, no, just exactly what Jared said. Rule is what we feel like we help the most with our technology, and we're going to continue to do that and expand this to areas that need that access. So excited that we, had the opportunity to tell you about it today. I think I don't have that article linked, Jared. Unfortunately, I think I got rid of that
Oh,
slide, but we'll make
that's
sure
fine.
that we get it to Haley and she'll send it out to everybody.
Yep. Will
Yeah,
do.
definitely. We will make sure that we get it included in the follow-up email. Just want to say thank you again to Dr. Anderson and Jared for joining us again today, and getting to learn all about what's going on with OSU Virtual Care. I know we had one question in the chat. We do have some time, so I'll give others a chance to enter that. For that first question, they were wondering, how do the rural underserved clinics pay for the subscription fees to the Title Care platform?
Yeah, so for us, let's see, we approach this, I would say, three different ways. So we've got one way is grant funding. We were able to have some grant funding for at least 2 to 3 years to help support this. The other way is philanthropic funds. Obviously, we've got philanthropic donors throughout Oklahoma State that we present to, and obviously are interested in some of those rural components when you look at behavioral health, school-based being one of those. That's kind of how we support that with a philanthropic effort. And obviously, when we look at that specifically with that group, we're in discussion of what does it look like to do something statewide medical across the state. So that's exciting. So all of these, that we're doing, some of these models are pilots. Some of these are more consistent, extensions of care that we provide today. And so pulling data, organizing that, really telling that story as part of that when we look at grant and philanthropic. The other, obviously, other kind of model that we have is a contract model or a service model that, we charge a fee for some of our hospitals. And so we're able to do kind of all three. So we partner it that way. Hopefully that answers that question. So yeah.
Yeah, awesome. Thank you. Looks like we have another question. Wondering if you can describe your work with healthcare trainee students to prepare to work in the virtual environment and with rural families.
Yeah. Yeah. Dr. Innes, you want to take that one?
Yeah, can you guys hear me okay
Yeah.
still? Okay.
Yeah.
Yeah, so we continue to kind of expand this at Oklahoma State. Obviously, education is important to us, and that's what we do a lot of, especially with medical students, PA students, nursing students, residents, and fellows. And so one of the initiatives from Oklahoma State University is to continue to expand that. We're looking at, kind of new exam rooms that are up to date with technology, that we could do some virtual visits and practice virtual visits within these exam rooms, and also integrating it into our programs, our residency programs, where they're seeing some virtual care visits. We do believe that virtual care is going to become more and more used in the future with healthcare. And so teaching our residents, medical students, PA students, that is an important part.
And one thing I'll add to that too, when we talk about our residents, right now with our behavioral health and psychiatry group, we support a third and fourth year resident to go through kind of a rural rotation through our ER and inpatient service line. So they get an opportunity to directly connect with those rural hospitals out west, wherever we're at in the state of Oklahoma that we have a service with. So it's great that they get incorporated in that. Yeah.
And then we have an internal medicine resident on our virtual care service this month. So they kind of, and then we are teaching a rural virtual care PA course this June. So kind of just some examples of how we integrate it into the education.
Yep.
Awesome. Thank you both. One other question we have, are you able to bill Medicaid for the CHW and mobile van services that you all offer?
I wish we were able to build that. So there was a bill, I want to say the state of Texas had passed maybe a year ago. I might be a little fuzzy, so you can fact check me on that. But the state of Oklahoma, I don't believe passed that just yet. So I'll have to follow up on this year if they're able to do it. Obviously, billing an E&M visit, we could do that through the van, but specifically for the community health worker, there's a newer model I think that came out. I want to say geared more towards kind of that, I want to say, care management approach, and I think it's a monthly kind of, I want to call it probably a per member per month. And so in that kind of model that looks at different auxiliary services or different auxiliary personnel that you could use, community health workers being one of those. We're investigating that to see if that's something that we could obviously, bill for. So more to come on that model. So that's very, very new in the last couple of weeks that we've just kind of looked at and researched. So
yeah, and we do feel like Vanessa and the community health part is such an important part of what we do. I think it's the connection to the community with her being there and just being able to provide support. So I don't see that going away for us. Of course, we'd love to be able to build those visits in order to maybe be a more sustainable model from that sense, but she's an important part.
Great, thank you both so much.
Yeah.
Looks like we have one other question. Can the OSU providers in Oklahoma deliver digital care to patients in other states such as Texas, Louisiana, Arkansas?
I'll answer that a couple of ways. And Dr. Anderson, from your side, you can add perspective to that. In terms of licensure, yeah, as long as we have license at that state, I think there's obviously a compact. I want to say there's a 22 or 28 state, again, licensure compact. Oklahoma is part of that. So obviously I think it's a higher fee for that medical licensure. But yes, to answer your question, yes, we would be able to. Dr. Anderson, you want to add any more to that?
Yeah, we definitely would be able to. One of our missions here right now with OSU is trying to, increase the access to care here in Oklahoma. So that's our kind of concentration. Right now, we are pretty inundated with service lines that we're providing across here. Maybe it's a model that we look at in the future. I think our concentration with our mission is to help as many. We have 80 rural hospitals in Oklahoma, and I believe 39 to 40 of them are critical access. So our hope, we actually had one close this year, unfortunately. So our hope is to prevent any of those closures from happening and to continue to help that community. But as we expand service lines, it's definitely a model that we may look at in the future.
All right, I think that covers all the questions we have in the chat. Thank you again so much to Dr. Anderson and Jared for joining us today. I'm going to share screens really quickly just to let you all know about some upcoming events we have. All right, so upcoming events wise, on June 17th, Telehealth Rocks, our partner program, along with HTRC, will be hosting a webinar featuring Dr. Ann Davis, who's the director of the Center for Children's Healthy Lifestyle and Nutrition out of University of Kansas Medical Center. The webinar is going to focus on nutrition and healthy lifestyles for rural children and families. So that's coming up on the 17th. And then on the 24th, we are going to have Dr. Tiffany Griffiths, who's with the Eastern Oklahoma Medical Center, coming to talk about how rural partnerships can help school-based telemedicine. So we look forward to having you all join us then. You will see for the first webinar on the 17th, you'll see a link in the chat to register for that one. So please feel free to join us. If you all would like a certificate of attendance, just as a reminder, please do email us at htrc@kumc.edu. Thank you so much for joining us today. We look forward to having you all next time.